everyone. Welcome back.
Now I would like to invite Dr. Neeraj Goyal, and he's going to speak on fully reabsorbable mesh for hernia repair, combining the best of both the world.
Good morning, everybody. Thank you so much, Dr. Mishra, Dr. Bhavneet Bhalla, for giving me this opportunity to share my experience on this, one of the most recent advances in the world of hernia surgery, the fully resorbable mesh. Not the biologic, I'm talking about the fully resorbable mesh. I bring compliments from my NG360 Academy and Max Super Specialty Hospital, Patparganj, where I regularly work. So, this very old statement that this search for the ideal scaffold, ideal mesh, ideal tissue for bridging, for reinforcing the hernia defect has always been there, even till now. We have seen the shift in available options as mesh from polyethylene to polypropylene. They were game changers. Even till date, they are being in use. They are in use everywhere. So before we talk about this particular mesh that I'm going to talk, how does the mesh work? Why a mesh was required? So Dr. B.B. Agarwal from our own country, he published this very interesting concept that it is mesh aponeurosis scar tissue. All these meshes, they are porous, they induce foreign body reaction, some aponeurotic tissue, collagen is laid down, and over a period of few weeks to months, this plate, this kind of masked tissue mesh complex prevents the further herniation. So we need a mesh to induce the foreign body reaction, some macrophage reaction, the M1 or M2 type of reaction, we will talk. So in principle, if we can visualize, once this kind of tissue is laid down, collagen is laid down, a foreign body is not required in the form of that mesh. Before we go further, we should also remember that recurrence of hernia or complications of hernia are multifactorial. It is not only mesh dependent. We very well know there are patient related factors, there are surgeon or surgery related factors. So when a recurrence or a complication in a post-operative period in any hernia happens, Dr. Tarun Mittal was showing, the mesh is always important, whether it is hiatus or any hernia. As of date, we have more than 300 options as a mesh. Broadly, if we divide them, we can classify them into permanent synthetic mesh, which are completely non-absorbable. Then the biologics came with a lot of promise, but we know that these biologic meshes have also lost their relevance because of the limitations, the flaws coming with them. And then always there has been a search for absorbable material. In the absorbable material, there has been polyglectin or kind of vehicle mesh, but their absorption time is so short that they could not be used as a sole molecule for manufacturing these meshes. Now we have this molecule called as poly-4-hydroxybutyrate, P4HB. The absorption time of this molecule is between 12 to 18 months from the time of its deployment. When we encounter a patient of a hernia, what is the job of a surgeon? We surgeons are required to diagnose and decide which surgery we want, will be best for, we need to individualize, and of course the discussion of mesh comes. So for me, today after deploying more than 100 such fully resorbable mesh in last almost 5 years, almost 56-57 months, I divide them into two, that is conventional non-absorbable mesh, be it a single layer mesh or a composite mesh, depending on in which plane we have to put this, and a fully resorbable poly-4-hydroxybutyrate mesh. So today I am going to talk about what is this molecule, poly-4-hydroxybutyrate, what we surgeons across the world have started seeing this. In India, this is something new, but in UK, US, and so many countries, surgeons individually have deployed more than 400-500 mesh in their case series. Because cost is a little less limiting factor there, they have got it approved from their government hospital agencies. India is still not so well organized on this side, so cost comes into the deployment. Why this is the most potent mesh today in our opinion, and my journey of 100 plus meshes, how did this start and today where I am, and what are the indications as on date. So this molecule is available since 2009 in the form of a suture. Monomex is the brand name by B. Braun, and since 2010 it is available as a mesh by the name of Phasix, or a composite mesh called as Phasix ST from BD, that is Bard. More than 70 very well large volume studies have been published on this mesh. So there are some vital, very peculiar scientific properties of this molecule. When I heard, when I read them, when I have experienced in last so many months, I have become a fan of this molecule as a surgeon. Why? So poly-4-hydroxybutyrate, the monomer of this is hydroxybutyrate. This is produced by Escherichia coli, the E. coli bacteria fermentation. So it's a naturally derived molecule. It does not contain any residue from the metal catalyst when the mesh is manufactured, unlike the synthetic meshes where these metal catalysts produce acidic reaction in the area where they are deployed. Now what happens, this hydroxybutyrate is a normal component of our human cells of brain, kidney, muscle and heart. Can you believe a molecule which is inherent, which is natural to our human body, is the molecule which is produced by E. coli and is used for manufacturing this mesh. So this molecule is not foreign to human body. The whole game changes here. Because it is not foreign, so the synthetic scaffold, all those meshes, they use to produce M1 type of macrophage response, which will result in that fibrotic thick plate. Wherever we do operate, we find that scar, the imbalance in the abdominal wall, wherever the foreign body, this mesh is placed conventionally. When we place a poly-4-hydroxybutyrate mesh, there is M2 type of macrophage response, which leads to change in collagen type from type 3 to type 1, and over a period of 6 to 8 months, around 12 months, the patient starts feeling as if there is nothing in the abdominal wall. This is what is the testimony of my patients when they come in the follow-up. How does this get disintegrated or degraded? It gets degraded in vivo through hydrolysis into water and carbon dioxide. So it is fully resorbed in 365 to 545 days. That is a very good absorption time for covering the requirement of a mesh to reinforce the abdominal wall. Resulting byproducts are easily metabolized from the site of their hydrolysis by Krebs cycle and beta oxidation. So unlike these absorbable scaffolds of Dexone or Vicryl, whose byproducts, they decrease the pH at the wound site. So these are the microscopic or tissue level advantages of this molecule. One of the most important requisite of a mesh is that it should support the abdominal wall on the parameter of strength. Now look at this graph. This is very interesting, that in the porcine model this was done. When the mesh has been placed, this is the mesh strength, the lower gray area, and this pinkish area is the tissue which is growing, the fibrotic tissue or the collagen. What happens on the principles of physics, like if we put an implant in the bone, a fractured bone, till the bone has united, the load is borne by the implant. Once the bone heals, then the bone is able to take the load and the patients are allowed to bear weight and walk and do all the activities. Similarly, when a mesh is placed, unlike a fully non-absorbable mesh where this foreign body remains, the fibrotic tissue which grows, especially at the edges of the mesh, there is a complete change, transition, sudden transition from this fibrotic plate to normal abdominal wall, where usually the recurrences happen and there are complications of meshes after the surgery. Unlike those full non-absorbable meshes, here what happens, because this mesh starts getting disintegrated after 7.5 months, gradually this collagen which is being laid down there, it starts taking over the function of the mesh. Therefore, it's a gradual transition from disintegration, degradation of the mesh and the tissue simultaneously being laid down. So patients don't feel this foreign body fibrotic reaction later on. And secondly, there is not sudden change in the abdominal wall where the mesh is placed, including its peripheries. In studies, it has been found that it is able to provide almost 3 times the requirement of normal abdominal wall strength. So, the strength of this mesh is no challenge at all. Now, since it is coming from E. coli, so it has inherent antibacterial properties. Preclinical studies were done. A group of animals were deployed with this polyfluorohydroxybutyrate mesh and some comparable non-absorbable synthetic scaffolds. Bacteria were inoculated after 10 days of surgery in the site of surgery where the mesh was placed, and in the following weeks, these patients who were having physics mesh or polyfluorohydroxybutyrate mesh, they did not have any complication whatsoever. They did not have any suppuration or in mesh infection, inflammatory changes requiring mesh explantation, which was the case in those comparable group. So it has got, even in the presence of MRSA, the performance is that it completely maintains its strength when MRSA was there. So this mesh was initially used for contaminated cases, contaminated settings where you could not put the other mesh. But over a period of years, when you can put a mesh in a contaminated case or an emergency surgery where strangulation is there, obstruction is there, why not in clean cases as well? Now, 2 variants of this mesh are available. One is called as the single layer mesh, polyfluorohydroxy mesh, or the physics mesh, and the other is the composite variant, which is polyfluorohydroxybutyrate ST mesh, Supragel technology. So to summarize again, this is a natural polymer. Hydroxybutyrate, the monomer form, normally occurs in human brain, muscle, liver and kidney. Produced by E. coli, maintains 100% of its strength at 56 days, even in presence of MRSA. Degradation only into carbon dioxide and water. 52% strength reduction by 7.5 months. So gradually it is reducing, but still it is able to maintain the required strength, completely absorbed in 12 to 18 months time. Not to mention, but still very important, whenever we are using such a mesh, it needs to be fixed with all absorbable things, whether it is suture or the tacker. How did my journey start with this? In May 2020, I deployed this mesh for the first time in open onlay ventral mesh hernioplasty. Why? Because a male 49 years presented with mesh infection, abscess, after 1 month of his surgery elsewhere. He was operated for bilateral inguinal hernia, TEP, with a Prolene mesh. He had suppuration presented to us, comorbidities were there. When we operated, sorry for the poor quality of the pictures, this is what we found. The mesh was there, frank pus was there. We needed to explant the mesh and do the peritoneal lavage, put the drain. To our surprise, during this procedure, we found a defect in the peritoneum in the right lower quadrant, a ventral hernia defect, right lower quadrant, which was not mentioned in the documents anywhere in pre-operative or during the discharge of the patient. So this might be that the surgery had some peritoneal rent or whatever may be the cause. No imaging also showed preoperatively that this hernia existed. So in the follow-up period, we found that anti-tubercular treatment was required because tuberculosis was positive in this case, in addition to the other comorbidities. So we continued to dress the patient, medically managed for 2 to 3 months. Finally, when he had all the wounds healed completely, we had to operate upon this patient who had these kind of clean openings of the discharging fluid, serous fluid, no active infection here. Because of this ventral hernia, we had to propose a surgery, and with a lot of courage, I said, we can use this mesh in your case. He agreed. We did this open onlay mesh hernioplasty. He healed completely without any complication till date. So almost 56 months have passed. In this May, it will be 60 months follow-up for this longest follow-up case. And then I continued to gain the confidence in subsequent months, and I operated upon all the types of hernia. I deployed this mesh, whosoever agreed. I published the first case series of this mesh last year, where the number till that time was 25, January 2023. It was published in March 23. Till that time, one of the cases had only recurrence, else there was no significant complication related to mesh. That recurrence was also a pseudo recurrence to say, because this lady was a case of carcinoma endometrium, already having undergone total hysterectomy, radical, and she had incisional hernia, where we did the procedure open and deployed this mesh. She had a recurrence of malignancy, very obese patient, so she had a pendulous abdomen where a recurrence could be counted. Otherwise, till now, even in 100+ cases, I have not seen a mesh infection or significant complication, which has encouraged me to continue to use this. There were cases where recurrent hernia was operated and the enterotomy happened, where we needed to do the closure with trimming of the previous mesh, deposited the repaired intestine inside, put this mesh. I have done this with stoma closures, prophylactic mesh plasty. All these cases have done without any significant untoward effect so far. So my indications for today for this fully resorbable mesh are ventral, inguinal, stoma closures, enterotomies, parastromal hernia. Recently we did with Sugar Baker one large parastromal obstructed hernia, hiatus hernia. Across world, these large studies are available. In these studies, various rates of recurrences are mentioned depending on the factors of hernia, how large the defects are, what is the technique that has been used, but they have all shown promising results with this mesh. So we may say that perhaps this is the best of both the worlds between synthetic and the biologic. Challenges for this mesh are lack of complete information with the surgeons so far. Higher cost, it is costing a lakh of rupee in India for a single layer mesh, about 15 by 15 centimeter, and 1.5 lakh rupees for a 15 centimeter composite mesh. But cost is a relative thing. We are paying in the name of robots and whatnot. So it's up to the patients to decide and not the surgeons whether they want this or not. To conclude my talk, I'll say that there are so many options available. This is one of the options, definitely a very promising one. My study is still going on. The goal of zero recurrence is still to be achieved in hernias, because this is a multifactorial issue, and the last word on hernia surgery has not yet been spoken. Thank you so much for a very patient listening. Thank you.
Thank you. I request all the speakers to come on the stage. Can I request the chairpersons to please felicitate our speakers? Dr. Abhilash, Dr. Deepak Subramaniam, Dr. Tarun Mittal, and Dr. Neeraj Goyal. I would also request all the fellows of FMAS that we will be having a group photo post this next session, post the 5th session. You can have your lunch post the photograph. We request you to collect your convocation outfit, your gowns and your caps from the registration counter, and be prepared for the photograph post the 5th session. Thank you so much. I would also like to request our international faculty to please fill up the presidential and the secretary form, the nomination form which has been given to you, and submit it to us. I request the organizing team and the audiovisual team to stay back. Before the lunch, we are going to have a group photograph on the stage. Thank you so much. Thank you, chairpersons, and thank you, speakers.